Hello students, good morning. Today we will continue our class in psychopharmacology. In the last class we have discussed the introductory part, and today we will discuss the drugs for major psychosis. Before going to the exactly to the antipsychotic drugs, the drugs of psychopharmacology basically can be grouped into four groups. That is, the first group is the antipsychotics, which is meant for all types of major psychosis. The second group is the anti-anxiety drug for anxiety and phobic states. Phobic, that means fearful state. And the third group of drug is the drugs for affective disorder, which is basically divided into two groups, that is the antidepressant and antimaniac. Antidepressants are used for minor and major depression. This group of drug is very widely used nowadays. And this, the second group, that is the antimaniac, these are used basically for mood stabilization and for this control of mania. And the fourth group is the psychotomimetic drug. This drug is this group of drug is clinically not used. These are basically drugs for abuse which are used by the drug abusers. So these are the four basic groups of drugs for psychopharmacology. Today we will discuss the first group, that is the drugs for psychosis, antipsychotic drugs. Now let us discuss the classification of antipsychotic drugs. The first group is the phenothiazine. This is the main sheet anchor of the treatment for psychosis. The drugs are, first group is the aliphatic side chain. It consists of chlorpromazine and triflupromazine. The second group in this is piperidine side chain drugs. Drug is thioridazine, quite widely used drug. Piperazine side chain, that is the trifluperazine and flufenazine. Out of these, this chlorpromazine is the oldest drug and still it is very effective drug. The second group is the butyrophone derivatives. The drugs are haloperidol, trifluperidol, penfluperidol, droperidol. So there are number of drugs in this group also. Third group is the thiazanthine. In this, the drug is basically the flupenthiazole. Other heterocyclics are the pimozide and loxapine. Atypical antipsychotics is the clozapine, aripiprazole, risperidone, zipasidone, olanzapine, amisulpride, quetiapine and zotapine. There are number of other drugs also. I would like to mention one Indian drug, that is the reserpine. This is the oldest drug which was used in our Ayurveda practice. This reserpine is one of the main drug for psychosis in Ayurveda. Though nowadays this drug, that is the drug which is obtained from this Ayurvedic drug, which is nowadays practically obsolete. So we have omitted it. Now the next is today we will discuss the pharmacological actions. The main action is on central nervous system. Obviously this is the drug for major psychosis which involves the brain. So the main action obviously will be the action on central nervous system. The salient actions are, first is it reduces the irritational behavior, agitation and aggressiveness. usually the patient is very aggressive, so all these symptoms are controlled. Then disturbed thoughts and behavior are gradually normalized, anxiety relieved, hyperactivity, delusions and hallucinations are suppressed. All phenothiazines, thiazanthines and butyrophenones have the same antipsychotic efficacy. There is no preferential drug for any type of psychosis. It is up to the clinician for the choice of drug. Performance and intelligence are relatively unaffected, but vigilance is impaired. This is very important. Very minutely, if you observe the patient, when these drugs are given to psychotic patients, externally it will appear, patient will appear normal because of performance and intelligence are not affected, but vigilance is impaired. Patient is less vigilant, becomes less vigilant. Now the next pharmacological action clinically, which is very important, is the extrapyramidal symptoms, which are linked to antipsychotic effects. Usually these drugs are given to psychotic patients, and most of these patients suffer from some of the neurological symptoms earlier, and the most common symptom is the convulsive disorder. So usually a large number of patients who come with psychotic disorder usually suffers from convulsive disorder earlier, and already they are taking anticonvulsants. When this problem arises and when this group of drug is given, the extrapyramidal symptoms appear as the threshold of seizure is decreased. That results in seizure precipitation as well as extrapyramidal symptoms. Now the chlorpromazine, as I said, I have discussed already, the lowers the seizure threshold and there is precipitation of fits. Sedative effect is immediate and tolerance develops with continued use of drug. Now this point is also very important, because patient of psychosis, when this drug is given, immediately antipsychotic effect is not there, but there is very sound sedative effect immediately. So patient becomes sedated and quiet, and this helps in treatment of the psychotic patients with this group of drug, because immediate sedation is there, and this sedation is not continued for pretty long time, because soon, about 2 to 3 weeks time, there is tolerance develops of this action, and no sedative effect is observed after 2 to 3 weeks of treatment. And antipsychotic effect takes weeks for action, but tolerance never develops. This is also very significant, because in the first 2 to 3 weeks it is the sedative action by which the antipsychotic action is controlled, and after 2 to 3 weeks the antipsychotic effect takes over and there is no sedative effect. Now the mechanism of action, exact mechanism, still it is not known, because as we all know, we don't know exactly how this drug acts in psychosis, but there are a number of theories which are there. The first one is it is potent D2 receptor blocking action. Phenothiazine, thiazanthine also blocks D1, D3 and D4 receptors. Blockade of dopaminergic projections to the temporal and prefrontal areas constituting the limbic system, and in mesocortical areas is probably responsible for the antipsychotic action. These are all probabilities. Dopaminergic theory of this schizophrenia envisaging DA overactivity in limbic areas to be responsible for the condition. Now, the exception is the clozapine. Clozapine has weak D2 blocking action. However, it has significant 5-HT2 and alpha-1 blocking action and is relatively selective for D4 receptor. Thus, antipsychotic action may depend on a specific profile of action of drugs on several neurotransmitter receptors. Now there is a new technique by which that is known as positron emission topography, in short PET, studies of D2 and other receptor occupancy in brains of antipsychotics rated patients have strengthened the concept what we have discussed right now. Now the next mechanism is dopaminergic blockade in basal ganglia causes extrapyramidal symptoms. We will discuss the extrapyramidal symptoms later on, while that in the CTZ, that is the chemoreceptor trigger zone, is responsible for antiemetic action. So we have gone through in detail the pharmacological action of central nervous system, which is the main action of antipsychotic drugs. Now the rest actions are, second is the action on autonomic nervous system. There is varying degree of alpha adrenergic block, weak H1 antihistaminic and anti-5-HT. The local anesthetic action, chlorpromazine, which is the oldest drug, it has been found to be a potent local anesthetic just like procaine, but it is not used as a local anesthetic because nowadays there are more effective and safe local anesthetics available, so this is not used because of its irritation. Now the next action is on cardiovascular system. It is to some extent important clinically. Hypotension occurs both central and peripheral way. It may cause hypotension. High dose of CPZ, that is chlorpromazine, directly depress the heart, and there are some obvious ECG changes. There is QT prolongation and suppression of T wave, which are clinically important. Now the next action is on a skeletal muscle. There is no specific action, but they reduce certain type of spasticity. But so in some specific spastic disorder, in cerebral palsy where there is spasticity, some clinicians prefer a small dose of this group of drug to combat spasticity. Then endocrines, there is increased prolactin level causing galactorrhea and gynecomastia. There is reduced secretion of gonadotropin. So if you think of a chronic antipsychotic patient, this psychiatric disorder patient which is suffering from major psychosis, there is typical bending of patient with gynecomastia, and there is galactorrhea. This is the typical look of a chronic psychotic patients. There is reduced secretion of gonadotropin, and rarely there may be amenorrhea and infertility in female. ACTH, that is adrenocorticotropic hormone release is in response to stress is diminished. So ultimately it is the prednisolone level which may be decreased. There is release release of GH is also reduced, but clinically it is not significant. So all these hormones are basically decreased, secretion is there excepting the prolactin level. Tolerance and dependence occurs within days or weeks after starting the treatment, but maintenance dose remains unchanged. This is clinically significant. Though patient develops tolerance, particularly tolerance of this sedative action, the antipsychotic action remains there and maintenance dose remains practically unchanged. Relatively, it is a relatively bland substance, so physical dependence probably is absent, though withdrawal phenomena etc. do occur, and very rarely there may be physical dependence, which is, as I said, is quite rare. No drug seeking behavior. Once treatment is complete, drug is withdrawn, patient never asks for drug usually. For a few words about pharmacokinetics. Oral absorption of chlorpromazine is unpredictable and bioavailability is low once it is used orally. So for immediate effect, for more consistent effect, intramuscular or intravenous route is preferred, which results in a high level of drug in body and there is immediate antipsychotic effect. The TR, that is the half-life of the drug, is quite long, that is about 30 hours. Most of the drugs, antipsychotic drugs, has got a long half-life, 30 hours or more. So there is, it accumulates in chronic administration because part of the drug is excreted in 24 hours, so some of the drug remains there, and with continued dose there is gradual accumulation of drug and there is deposition of drug at different sites like liver, spleen, kidney or any other organs. It may get deposited, and once the drug is withdrawn, gradually those comes in circulation and gradually excreted out, and it is said that metabolites are excreted for months and years after discontinuation of treatment. So in some cases it has been found that for lifelong the metabolites of antipsychotic drugs are present in urine when it is examined. Now there are a number of drugs. This is a flow chart which shows the characteristic of different antipsychotic drugs. There are four or five parameters in this chart. First is the dose, second is the extrapyramidal action, third is the sedative action, fourth is the hypotensive action, and last one is the antiemetic action. The dose, if you go through the chart, it varies from very low dose to quite high dose. So range is quite high, quite large range. Usually drug is given to start with low dose, gradually it is increased so that there is optimum effect. Once optimum effect is achieved, drug remains on that dose. For example, chlorpromazine, its dose varies from 100 to 800 milligram. To start with, it is given 100 milligram. Gradually, it is increased when there is optimum effect is achieved, drug dose is not increased beyond that, and that dose is continued. Same is if you go through the chart with the other drugs also. For example, this haloperidol, it is 2 to 20 milligram. Rather, less than 2 milligram is also advised. 0.5 milligram tablets of haloperidol is also available. So very low dose to start with, and it is continued with slight higher dose day by day unless and until optimum effect is achieved, and then continued with that dose. So try to remember the dose of these drugs, and the rest properties of the drug are shown with plus. The plus, more of the plus, that is the effect is more. For example, this chlorpromazine has got 4 plus selective action, sedative action. That means it has got a very high sedative property. That's why this is the first line of drug for as an antipsychotic drug. Once it is given, immediately patient gets sedative action and patient is controlled. Hypotension has got 3 plus, that means quite high hypotensive effect is also there. There is 2 plus antiemetic, that is average antiemetic action is there. Extrapyramidal 2 plus, that is there is extrapyramidal action is, it occurs, but it is less in comparison to other, where there is, you can find 4 plus action or 3 plus action. Like in triflupromazine, there is 4 plus extrapyramidal action. In haloperidol, there is 3 plus. So this varies, that shows the intensity of action of a drug. So you go through it, and it is some of the trade name are also there. So you are not concerned with that much, but you must remember the dose and the main activity, that is the extrapyramidal, sedative, hypotensive and antiemetic property. So this finishes our pharmacological actions of drugs for major psychosis. In the next class we will discuss the adverse effects and therapeutic uses of antipsychotic drugs. Thank you very much.